Thanks, everybody, for joining us. My name is Dr. Dan Dreyfuss. I'm one of the medical advisors for Astaria Global, and joined on the call also by Dr. Stuart Shoemaker, who is the other medical advisor to Astaria Global. And we're here this evening to talk with you about some of the work that we've done looking at autologous alpha-2 macroglobulin for managing equine asthma, and the pilot study that we did and the work that we plan to do as we move forward. So again, that's the team that's involved. So really the star behind this entire system is the alpha-2 macroglobulin molecule. It's a very interesting molecule. It's been known for many decades as part of the innate immune system. Its primary function in life, the reason it's been conserved evolutionarily across all vertebrates and many invertebrates, is to fight against foreign invaders, invading pathogens. But the way that it does it lends itself to being actually quite a potent anti-inflammatory. The molecule is mainly synthesized by the liver and released into the peripheral circulations, although there are smaller amounts that are synthesized by many other cell types. In fact, virtually every cell type that they've looked at to see if it expresses alpha-2 macroglobulin actually does in small amounts. It's a relatively large molecule. It's a homotetramer, so it's made up of 4 identical subunits configured into a complex structure, has a molecular weight of about 720 kilodaltons. And there are some striking similarities between alpha-2 macroglobulin and parts of the complement system, which again, as part of the innate immune system, makes perfect sense. What's very unique about alpha-2 macroglobulin is its mechanism of action. It has at least 3-pronged mechanism of action, and these 3 prongs, these 3 mechanisms of action, have not been detected for any other molecule that we're aware of. Primarily, it's known as a non-specific inhibitor of all 4 classes of proteases. This does include the matrix metalloproteinases, or MMPs, and the adisintegrin and metalloproteinase thrombospondin motif, a big long mouthful. That's why they gave it the acronym, the ADAMTS. These, as I'm sure you're aware, these are the 2 groups of proteases that are most responsible for degrading the ground substance in all mammalian tissues, such as the collagenases, aggrecanase, stromolysin, etc. And they do play a significant role, interestingly, in equine asthma. The second thing that the molecule is noted to do is that it is a growth factor or cytokine modulator. By that, we mean that there are specific binding sites on the alpha-2 macroglobulin molecule for pro-inflammatory cytokines, interleukins 1, 2, and 6, as well as tumor necrosis factor alpha, or TNF-alpha. And the third thing that we know about the molecule, which is perhaps the most interesting from an academic standpoint, and perhaps has the greatest ramifications from a clinical standpoint, is that the molecule has been demonstrated in a model of post-traumatic osteoarthritis looking at chondrocytes. I know there are no chondrocytes involved in the function of the lung, but this was the model that they used. When they looked at this post-traumatic osteoarthritis model, supplemental alpha-2 macroglobulin was actually demonstrated to upregulate anabolic genes and downregulate catabolic genes. So it increased expression of good proteins, such as type 2 collagen and aggrecan, and downregulated the production of several different matrix metalloproteinases, and please keep that in mind as we move on to talk about asthma, as well as a couple of other catabolic factors for cartilage. So this hasn't been demonstrated in a lung model yet, but it's very interesting that the molecule has the ability to alter gene regulation, gene function. So as a result of this 3-pronged mechanism of action, it's far more than just a protease inhibitor, and it's actually been described by an immunologist as acting as an anti-inflammatory, or as the body's natural anti-inflammatory molecule. The way that it does it is also quite interesting. It is basically a molecular analog of a Venus flytrap plant. So on the left in this graphic, you have a molecule in its native or wild type configuration. It has, if you will, outstretched arms. And when in this configuration, there is a bait region. It's a string of amino acids that's offered up to protease enzymes, those little green Pac-Man looking guys. When the protease comes along and does what proteases do, cleaves an amino acid segment, the molecule undergoes a physical conformational change. And there are at least three very important consequences of this conformational change. The first is that it traps that protease molecule within this cage. And this was literally dubbed the trapping mechanism by the British biochemists that worked this out and published it 51 years ago. At that point, that protease enzyme is sterically inhibited from attacking any of the substances it would normally degrade. The second important consequence is that the binding sites for those pro-inflammatory cytokines lay down underneath those outstretched arms in the wild type configuration. When those arms sweep up, those binding sites are better exposed, and biochemists have actually measured, and the binding affinity for those pro-inflammatory cytokines is significantly higher when the molecule's in this closed or trapping configuration. And then the third thing that's important about this conformation is once the molecule has bound a protease and bound pro-inflammatory cytokines, then and only then there's a binding site that is exposed. It's recognized by macrophages that bind to it, can phagocytize, engulf the entire complex, and remove these pro-inflammatory mediators from the site of inflammation. So this molecule doesn't simply block the activity of other molecules. It actually binds them and physically removes them from a site of inflammation. And that's an important distinction from a lot of the other orthobiologics that are available on the market. So there's not been a lot of research looking at alpha-2 macroglobulin in the respiratory tract to this point. There was one paper published a couple years back that identified a long non-coding RNA, and this long non-coding RNA is noted to inhibit lipopolysaccharide-induced inflammation and programmed cell death or apoptosis in bronchial epithelial cells. They noted that in people with COPD, that both this long non-coding RNA and alpha-2 macroglobulin are downregulated. And they also noticed the same condition when they exposed cultured bronchial epithelial cells to lipopolysaccharide in vitro. So what they then found was that alpha-2 macroglobulin is positively regulated by this long non-coding RNA. They were able to determine which exact pathway by which it does it. And they noticed that if you eliminate the gene for alpha-2 macroglobulin, you also eliminate the ability of this long non-coding RNA to inhibit the effects of lipopolysaccharide on bronchial epithelial cells. So the conclusion that the investigators reached was that the results confirmed that this long non-coding RNA can inhibit LPS-induced bronchial epithelial cell inflammation and programmed cell death, and it does so by promoting alpha-2 macroglobulin expression. So this shows how alpha-2 macroglobulin plays a role in an anti-inflammatory effect in a different model. It's not asthma, it's COPD, but there's far more similarities between COPD and asthma than there are differences between the two. So I thought this was a really interesting paper demonstrating a role in this process for alpha-2 macroglobulin. So if we talk a bit about equine asthma, it's not the purpose of this talk to make everybody experts on equine asthma, but I just want to bring up some of the highlights of it because they're important to keep in mind when we're considering the therapeutics and the role that alpha-2 macroglobulin might play. So first and foremost, equine asthma is caused by environmental dust. There is a potential role for infectious agents, be they bacterial or viral. In the most recent consensus statement released by the American College of Veterinary Internal Medicine, they divided equine asthma into two different subcategories. The mild to moderate form of equine asthma is now called inflammatory airway disease, or IAD, and the more severe form is referred to as recurrent airway obstruction or summer pasture-related airway obstruction. The clinical signs, I think everybody on this call is well aware of those clinical signs: coughing, increased respiratory effort. Poor performance or exercise intolerance. Often poor performance or suboptimal performance is the first clinical sign that particularly young horses with inflammatory airway disease will show. And of course, nasal discharge is quite common, especially in those horses that produce a lot of mucus. The diagnosis, it's not the toughest thing in the world to diagnose. There are various levels that can be attained as far as diagnosis goes. It can be based simply on clinical signs and appropriate response to appropriate treatment or management. Again, it can be detecting those signs, changing the management of these horses, seeing how they respond. For most, that is considered an adequate diagnostic. You can add endoscopy, looking for the presence and abundance level of tracheobronchial mucus. Bronchoalveolar lavage is done quite often. Typically, this is done more in universities or referral settings where you can analyze the cell levels of things such as neutrophils, eosinophils, or mast cells. This can be done both as a diagnostic, can also be used as a response to treatment in addition to clinical signs. And for research purposes mainly, pulmonary function testing can be done, and most horses with equine asthma, especially the more severe forms, will manifest some level of pulmonary dysfunction because of the disease. The prevalence of equine asthma is strikingly high. There's a paper published again within the last few years that has demonstrated that the prevalence of the mild to moderate form, inflammatory airway disease, are as high as 60 to 80% of the equine population. And this was based not just on clinical signs, but also on bronchoalveolar lavage. And as far as the more severe form goes, the prevalence is estimated at between 14 and 17% of the population. The pathogenesis is not completely understood. It is known, or it is felt, that there is some level of dysregulation of inflammatory cell homeostasis within the airway lumen. It's a big, long mouthful. Basically, it's an inflammatory process run amok within the airways. If you look at some of the gene expression, you'll see increased levels of pro-inflammatory cytokines such as IL-1 beta, TNF alpha, and some of the more inflammatory interferons. You'll also people have measured increased levels of these cytokines within bronchoalveolar lavage fluid. There's certainly a role for genetics. There are certain lines within certain breeds that are overrepresented when it comes to equine asthma. There was a paper published just 2 years ago that looked at a variety of different risk factors amongst the equine population for developing equine asthma. And strikingly, the only factor that was statistically significant as a risk for developing equine asthma was obesity. Those horses with a body condition score of greater than 7 are at a higher risk for developing asthma than those horses with a lower body condition score. So just as people are doing to ourselves, we're doing the same to our horses. We're killing them with kindness, and by overfeeding and under-exercising, producing obese horses, we're increasing the prevalence of equine asthma within the population. The other thing that's involved in the pathogenesis of equine asthma, I find quite interesting. I was not aware of this until I took a deeper dive into equine asthma, and that's the role of protease enzymes in equine asthma. And there is a documented imbalance between levels of proteases and antiproteases that contribute to the dysregulation of inflammation and subsequent tissue changes and damage that occur in equine asthma. So it circles back to when we were talking about the pathogenesis and this dysregulation of inflammatory cell homeostasis in the airway lumen. Proteases play a key role in that. And as we spoke about earlier in the mechanism of action of alpha-2 macroglobulin, that's its principal function, is to inhibit proteases. So I find that rather interesting, and perhaps that's why we're seeing the results that we're seeing in a pilot study that we performed. So if we dive a little deeper into some of these proteases in asthma, there are 2 in particular that are quite well documented as playing a role in asthma. The first is neutrophil elastase. It can cause several detrimental effects, including destruction of the extracellular matrix within the airways, hyperplasia of mucus glands, and increased mucus production. And it also affects the beating rate of cilia, so it slows them down so they're not as efficient as clearing that mucociliary elevator. And it can cause direct damage to the airway epithelium. Ne is found in the primary granule of neutrophils. It's also called MMP12. So neutrophil elastase is actually a matrix metalloproteinase. It's been demonstrated in several studies to be upregulated in asthma. It's been demonstrated to propagate inflammation, and it's recognized in the human field as a potential therapeutic target for managing people with asthma. So the second protease I just want to mention really quickly is MMP9. It's one of the matrix metalloproteinases. It happens to be one of the matrix metalloproteinases that was downregulated in those chondrocytes in the original paper that demonstrated a gene regulatory effect for alpha-2 macroglobulin. They weren't looking at bronchial epithelial cells, they were looking at chondrocytes, but it specifically decreased production of MMP9. And MMP9 sources for that within the respiratory tract include inflamed bronchial epithelial cells, as well as several different types of white blood cells, neutrophils, eosinophils. It's present in mast cells. It's also present in macrophages. Levels in people with asthma are increased in asthmatic versus normal patients, and they're further increased in severe asthmatics versus mild asthmatics. So it's an interesting molecule to consider when, whoops, didn't mean to change slides there. An interesting molecule to consider when we're looking at the pathogenesis of equine asthma and the role that proteases might play. It's also very interesting that there was a paper published a few years back, actually, not much attention was paid to it, but specifically MMP9 is activated in horses by dust found in hay. So there's definitely a lot of curiosity around the role of proteases in equine asthma. The heterogeneity, if you will, of the inflammatory response in asthma is indicative of differential regulation of protease activity in asthma. This could be due to a variety of things, including ineffective anti-protease or protease inhibitors. So all of this is to say that it creates a story where lending inhibition of proteases to asthmatic patients are a potential therapy for asthma, be it a person or a horse. Current treatments for equine asthma, again, I think everybody on this call would be pretty familiar with most of these. Management changes, well, first and foremost, all the treatments revolve around trying to decrease lung inflammation. Management changes can be incredibly effective in managing equine asthma. Some horses do well outside and are horrible inside a barn. Some horses are horrible inside a barn and do great outside. You have to find the right management change for that. Steaming or wetting hay, knocking down dust in barns, use of fans to improve ventilation. For most horses, that's going to be a benefit. A variety of management changes. Corticosteroids have traditionally been at the forefront and the central means of managing horses with asthma, whether they're systemic or inhaled. But as you all know, corticosteroids are not appropriate for every horse that we deal with, and we'll get to that a bit more later. It's been demonstrated that supplementing feed with omega-3 fatty acids is beneficial for some horses with equine asthma. Bronchodilators, such as clenbuterol, are used on horses with equine asthma, as well as mast cell stabilizers, such as cromolyn sodium. And some people have even tried some of the interferons as a means to try to manage equine asthma. As you can see, because there are so many things available, and this is not a complete list, the indication is that there's no one thing that works for every horse that has equine asthma. And it's a matter of finding what combination therapy is going to work best for each individual that has equine asthma. So with that said, let's talk about some of the results that we saw when we looked at nebulizing alpha-2 macroglobulin in the form of alpha-2EQ to horses with equine asthma. As part of our due diligence, when we came up with the thought to nebulize alpha-2EQ to horses with equine asthma, we wanted to make sure that we weren't going to be harming any horses. We found a group of very mildly affected asthmatic horses. These were all diagnosed on the basis of both clinical signs and BAL. And we wanted to assess in this group of horses whether they had any adverse events to the nebulization protocol that we designed for looking at asthma. That protocol is to use 3 mLs of alpha-2EQ diluted to 6 mLs with saline. The nebulizations take place every 48 hours, and the initial series is for 6 nebulizations. There is a weighted clinical score. This is a score that is based on the severity of 9 respiratory-related clinical signs. It actually was used to get an FDA CVM approval for a drug here in the United States, and we used that as our objective outcome measure for efficacy when looking at this initial study as well as the subsequent study. So what we found when we looked at these horses when they were nebulized according to this routine is that there were no adverse events. It was quite well tolerated. First and foremost, we wanted to make sure that none of the horses actually had a serious adverse event. Seizure, death, none of those occurred whatsoever. We looked at temperature, pulse, and respiration prior to and 1 hour following nebulization, and there were no significant changes. There were no horses in this group that had increased coughing associated with the nebulization, and no horse developed a nosebleed or epistaxis as a result of the nebulization. So we felt pretty comfortable that, at least in this group, it was well tolerated. We also looked 1 week following the last of the 6 nebulizations at their weighted clinical score and compared it to the weighted clinical score that was taken on day 0, the day they started their nebulization. So you have day 0 and then 7 days following the 6th of 6 nebulizations. And what we found in this small group of 8 mild, very mild asthmatics was that the weighted clinical score for 7 of the 8 improved. And this is just a quick bar graph to represent those results. So you actually had 7 of the 8 horses went from a low score at the outset down to 0. 1 horse actually increased 1. Based on these results, we've decided this looks like it might be worth taking a look at in a larger group of horses that aren't just very mildly affected with equine asthma and see what the clinical effect and the safety is. So we launched our pilot study. It was an open label, single arm, non-randomized, non-controlled pilot field study simply to look at the effects, the safety, and the efficacy of alpha-2 macroglobulin from alpha-2EQ for managing equine asthma in this group of client-owned horses. To be included, they had to be diagnosed with either the mild to moderate form or inflammatory airway disease, or the severe form of equine asthma, recurrent airway obstruction. They had to have demonstrated at least 1 clinical sign of equine asthma for 2 weeks or more prior to enrollment. They had to have a history of at least 2 prior episodes of labored breathing at rest to be included. And they had to, importantly, have demonstrated improvement with appropriate history or appropriate treatment in their history. The protocol for the nebulization schedule was essentially the same as it was in the original study. They had to be diagnosed again with equine asthma based on their clinical signs and or BAL. Not all of them had BAL. A lot did, but not all. They had to have a pre-treatment weighted clinical score assessed. That score had to be greater than 7 to be included in the study. And again, this weighted clinical score comes from a paper based on 9 clinical signs I'll get to in just a moment. They then went through their 6 nebulization series with alpha-2EQ. Same protocol, 3 mLs of alpha-2EQ, dilute to 6 mLs with saline. We preferred that they were off all other medications for greater than 7 days prior to entering the study. However, if they could not be taken off of other medications because their asthma was too severe, they were allowed to remain on those medications right up to introducing the Alpha2EQ as long as their weighted clinical score was greater than 7, because that was an indicator that clinically the horses weren't responding well enough to whatever treatment modalities they were on at the time, and Alpha2EQ was going to be an addition to that treatment regimen. No management changes were allowed for any of the horses during the time of the study. They couldn't be moved to a different barn. They couldn't be housed in a different part of the farm. They couldn't start to wet or steam their hay during the study. Typical non-introduction of a confounding factor. And then 7 days following the last of the 6 nebulizations, their weighted clinical score was assessed for the final time. This is a chart to indicate what the 9 clinical signs are. It's way too busy a slide. If anybody is interested, certainly can give you the reference that this weighted clinical score was taken from. So what we were looking at, we wanted to look at first and foremost safety. Were we doing any harm to these horses? And we used the weighted clinical score as our objective outcome measure for efficacy. Prior to the study, we defined success as being a reduction in weighted clinical score of at least 30% at the 7-day post-nebulization compared to their baseline pre-nebulization. And they had to have a final weighted clinical score of less than or equal to 7. So there were at least these 2 criteria they had to meet to be termed a success. We were able to recruit 54 horses from 8 different sites at different geographic locations around the United States, because the geography, the allergen levels, the weather are all quite different depending on which part of the United States the horses happen to reside. And what did we find? From a safety perspective, there were no serious adverse events reported. There were no significant changes in temperature, pulse, and respiration 1 hour post-nebulization. No horses developed bloody nose or epistaxis. There was 1 horse that did develop a transient increase in coughing with nebulization, but that horse actually was reported to do the same thing even when nebulized with saline. From an efficacy standpoint, the results were quite pleasing to us. Of the 34 horses that met inclusion criteria, by the way, there were 20 that we could not include, several of which, unfortunately, because the investigator did not get the weighted clinical score at the appropriate time or forgot to get it altogether. There were also several horses that underwent management changes, which were prohibited, and they were excluded from the study data analysis. Of the 34 horses that met the criteria to be included and had all the data that we could analyze, 30 of the 34, or 88.2%, met the objective outcome measure defined as a success. This is pretty striking. The approved product, the most recently approved product for equine asthma through the FDA CVM, in their pivotal clinical efficacy study, had a success rate of 52%. So we were quite pleased with the 88.2%. Of the 34 horses, all 34, or 100%, had a lower post-nebulization weighted clinical score than their pre-nebulization weighted clinical score. And 32 of the 34, or 94.1%, improved at least 30%, but they did not attain a final weighted clinical score of 7 or less, so they could not be termed a success. There was one horse that experienced transient increase in coughing, and again, no significant changes in temperature, pulse, and respiration, and no horses developed a bloody nose. As time has gone by, we've been able to look at some of these horses later on so that we could assess their duration of response. And that's varied anywhere between about a month to several horses that are ongoing greater than 6 months, some of them off of all other treatment modalities completely. For those horses, typically those that had a higher initial weighted clinical score, they've been a lot of them have been maintained on a single monthly dose. This isn't a whole series of 6 again. It's a single dose at approximately 1-month intervals. And there are some horses, depending on the clinical signs that they demonstrate, that are maintained on intermittent or some of them on continuous, different medications to manage the specific clinical signs that those horses manifest. There's a couple interesting things that we found as a result of this. One, in some horses in the study and some other horses that weren't included in the study, this is all from evidence that we've gathered with the clinical use of Alpha2EQ for managing equine asthma. There's several horses, both in the United States and over in both the UK and Europe, that have had BALs performed post-treatment protocol. And we found in several of these horses that they went from a quite inflammatory protocol at the outset, which you would imagine because they're asthmatic, to having a completely normal BAL 7 days after the nebulization regimen was concluded. It's not going to happen for every horse. I do think it's very interesting that it has happened in the number of horses that it has, and I think this adds some evidence that this alpha-2 macroglobulin may be exerting a cellular effect in these horses with equine asthma. We've run into a couple of things that where there are some problems associated with the nebulization of the alpha-2EQ. Those horses that tend to produce a lot of mucus, a tremendous amount of mucus, have not responded quite as well as those that don't produce a tremendous amount of mucus. I think that this might be because that mucus layer is actually forming a barrier and not enabling the alpha-2 macroglobulin to get to the bronchial epithelial cells. So in these horses, if you know that they are a heavy mucus producer, treating them with any of a variety of different medications to combat that mucus, whether it's clenbuterol, sputolysin, acetylcysteine, the list goes on. I'm sure you have your favorite recipe for trying to manage these difficult to manage horses, but doing that prior to initiating the nebulization series, I think will give you great benefit by cutting down the amount of mucus and literally allowing the alpha-2 macroglobulin to get in contact with its target tissue, the bronchial epithelium. We also are asked several times, do a particular group of horses of asthmatic horses respond better than others? For instance, horses with a lot of mast cells, do they do better or worse than horses with neutrophils and eosinophils? We don't know. We haven't done enough horses where we have all of that information to be able to assess it in a statistically significant way. So we don't know that yet. When we have enough numbers, we certainly will look to see if there are a particular type of horse that seem to respond better than others. We do. Having said that, we know of horses that did have a lot of mast cells that responded quite nicely, and some with a lot of mast cells that didn't respond quite as nicely. Again, equine asthma is multifactorial. Not every horse is going to respond to every medication, and I think combination therapies are going to be the wave of the future in managing this, and adding alpha-2EQ to the mix could potentially be quite beneficial. So again, these are preliminary results. There are limitations to this study. It wasn't blinded and controlled. It was not a huge number of horses, and there weren't enough for us to analyze things statistically, but the results are encouraging. We're asked again quite frequently, what's the effect of nebulizing alpha-2EQ to horses that have exercise-induced pulmonary hemorrhage, or EIPH, bleeders? We don't have any numbers yet. It's anecdotal only. It's mainly been in barrel horses, and the reports from several riders at a very high level is that it is having a profound beneficial effect for these horses. They're performing better, they're recovering better. A lot of these riders are doing the initial nebulization protocol and then following with a single dose anywhere from 3 to 48 hours prior to their event, depending on the rules and regulations. We do have some next steps planned as far as studies go. We just concluded a blinded controlled study of clinical cases of asthma in conjunction with one of the veterinary schools here in the United States. In addition to the clinical responses, we're also looking at cytokine and cellular responses within the BAL fluid. The study is complete. Unfortunately, we do not yet have all the data analyzed to be able to share it with you, but we hope to have that in the very near future. And we are about to actually have enrolled the first couple of horses, looking at the effects of the same nebulization protocol for helping manage EIPH in racing thoroughbreds and 3-day event horses during the cross-country phase. Both of those groups, subpopulations of horses, and the problem of EIPH is very complicated, obviously multifactorial, but there is an inflammatory component, so we feel that nebulizing Alpha2EQ may have some benefit, and we hope at a relatively short time in the future to have results, at least preliminary results of those studies. So thank you very much for your time and attention, and we look forward to meeting back with you in the near future to answer any questions that you might have.